Good morning, good afternoon, and good evening, and welcome to the first NCCN Global Policy webinar this year, the utility and value of national cancer control plans across the economic spectrum. My name is Katie Winkworth-Prejnar, and I'm the Senior Manager of Global Policy and Strategic Alliances at the National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading academic cancer centers dedicated to improving and facilitating quality, effective, equitable, and accessible cancer care. Through the leadership and expertise of clinical professionals at NCCN member institutions, NCCN develops resources that present valuable information to numerous stakeholders in the healthcare delivery system. NCCN guidelines and clinical content is utilized throughout the world. Last year, there were 13.3 million guidelines downloaded, and nearly half of those downloads were accessed outside of the United States. As you can see from this heat map, NCCN guidelines are utilized in nearly every country around the world. NCCN appreciates and recognizes the supporters and sponsors for this webinar series. Truly, without your support, this webinar would not be possible. Thank you. Today's program will focus on the core elements of evidence-based national cancer control plans, as well as similarities and differences of NCCPs across countries. Our truly esteemed group of speakers will also focus on the importance of implementation, determining value, ensuring equitable access, and measuring outcomes of NCCPs. The program will begin with a presentation from the International Atomic Energy Agency, IAEA, on the global opportunities and challenges in the implementation of national cancer control plans. Next, we will hear from the former director of the National Cancer Institute, Argentina, on ensuring equity in national cancer control plan development and implementation using the real-world example of Argentina. Lastly, we have an esteemed group of panelists who will discuss these issues in more detail and share their insights and expertise with implementing NCCPs into practice. Our moderator for today's webinar is Dr. Weijing Ko. Dr. Ko is Senior Vice President and Chief Medical Officer at NCCN. He oversees the NCCN clinical practice in oncology and actively is involved in NCCN global initiatives. At this time, allow me to briefly introduce our keynote speakers. Lisa Stevens joined the International Atomic Energy Agency in June of 2019 as the Director of the Division of Program of Action for Cancer Therapy. Prior to joining the agency, Dr. Stevens spent 24 years in various roles at the U.S. National Cancer Institute, including as Deputy Director of the Center for Global Health. She co-founded the International Cancer Control Partnership, ICCP, in 2012 with the Union for International Cancer Control. We will then hear from Dr. Julia Ismail. Dr. Ismail is a specialist in clinical oncology. She worked at the National Cancer Institute for 9 years and was its director between 2018 and 2020. As a medical oncologist with a focus on population health equity, she works to improve systems of care and reduce cancer disparities. She has contributed to numerous cancer control programs, including the launching and implementation of the first National Cancer Control Plan in Argentina. We are thrilled that both speakers are here today to share their expertise with you all. Their presentations have been pre-recorded, but we welcome the opportunity to answer your questions during the live panel discussion. We look forward to an active conversation today, and please submit your questions in the Q&A chat, and please engage throughout the program. Thank you.
I want to thank the NCCN for inviting me to talk today on global opportunities and challenges in the implementation of national cancer control plans. My name is Lisa Stevens. I'm the Director of the Program of Action for Cancer Therapy at the International Atomic Energy Agency, and also a co-founder of the International Cancer Control Partnership, which I will talk about later in the presentation. So we all hopefully recognize that cancer is a global challenge, and that by 2040, there will be an annual estimate of 30 million cancer cases globally. And the burden is really going to fall on low and middle income countries. And these countries often lack access to diagnostic and treatment services. And we think that national cancer control plans can help in this regard. In addition to the rising burden, there's also insufficient funding. So while there's a huge burden of mortality in low and middle income countries, only 5% of global spending on cancer goes to low and middle income countries. So this is one of the challenges that we feel that national cancer control plans can address. A little bit about the Program of Action for Cancer Therapy. We are within the International Atomic Energy Agency, so we do have a technical focus as an agency on radiotherapy, nuclear medicine, medical imaging. But PACT has the advantage of being able to look at the entire cancer control continuum and ensuring that radiation medicine, so those nuclear applications, are well integrated into comprehensive cancer control. And one of the services that we provide from PACT are impact reviews. And I want to spend a little bit of time because these assessments that are done in partnership with the World Health Organization, with the International Agency for Research on Cancer, and other international experts are a baseline or maybe an initial step in the development of a national cancer control plan. So the impact reviews are an assessment of the country's cancer control capacities and also where the needs and gaps are. And we help through the report that's given to the Ministry of Health to provide a list of priority interventions that would help a country respond to its cancer burden. So this is really a baseline situational analysis and evidence-based recommendations that, again, are delivered directly back to the Ministry of Health for prioritization and incorporation into national strategies. And because this is done with multiple UN partners, with international experts across the cancer continuum, there are recommendations from prevention all the way through palliative care that a member state can choose to adopt. Again, this can be a first step in the National Cancer Control Plan development, which maybe I'll just start referring to as NCCPs, because it is this both situational and stakeholder analysis. So it's not only what capacities are available, but who in the country might be able to provide support to a government, to a Ministry of Health, to be able to increase the capacities. It is contextualized. The recommendations are country specific, and again, they're evidence-based. There is opportunity for the government to express interest in a national cancer control plan during the impact review phase. And this NCCP expert service that we have been developing here with Impact would be tailored with a set of terms of reference, again, taking into account what some of those recommendations are from the impact review or from other assessments that a country has performed that need to be considered for the development of the plan. We have many examples from member states who have gone through the impact process, and one is Sri Lanka. And this was one of the last missions we were able to do before COVID. And as a result of the impact review, the country decided to develop a strategic plan, both for childhood cancer and also specific for radiotherapy services. So these are just some of the ways that the assessment can be tailored into strategies focused on either the entire cancer control continuum or specific aspects. So let me get in a little bit into cancer control planning, just so we're all coming from the same place. So there are multiple phases, the pre-planning, the where we are now, again, that's the impact review, that assessment, where do we want to be, the strategy, the vision, and then how do we get there, the plan. It's this, what is it? It's really a strategic approach. Again, the cancer continuum keeps coming up throughout the presentation because it's important to show that there are linkages, that maybe you don't start your prioritization at the first early stages, but maybe it's a little bit in each of the stages. We have to make sure that we're looking at various components of the health system to address the cancer burden. It's not only about treatment, it's not only about prevention, but it's about a balance. Again, the needs assessment is important to understand where the country is. And the plan needs to include elements across this entire continuum. As I mentioned, within PACT, within IAEA, and across the UN partnership, we are building up this advisory support for planning, because we want to make sure that it's responsive to member states' needs in order to provide this evidence-based plan. We want to support the country in strengthening a National Cancer Control Steering Committee that would be able to see through the development of the plan. And then as we talk about implementation, that steering committee can be reconstituted. Some of the members can stay on. It can be exactly the same for the implementation. And that there's also that upfront thought about monitoring and evaluation and how to report back to the stakeholders, to the decision makers, to the public on what some of the accomplishments were under the auspices of the plan. I mentioned specifically with Sri Lanka that they took their impact review recommendations and were able to turn it into some very specific planning tools. There are opportunities to link the NCCP to resource mobilization strategies, including an additional service that we provide here in PACT, which are bankable project documents, which can be used to mobilize national resources or resources and support from international entities, regional development banks, private sector, other donors. The plan can also be used to develop projects on cancer control. Within IAEA, we have a technical cooperation department that supports specific activities, both at the national, regional, and interregional levels. And an NCCP it can be the basis for devising those TC projects. And the NCCP can also support the development of a national cancer control program. The support to a member state in cancer control is really meant to be a long-term relationship. And so I have a couple of member state examples here where the first impact review in Uzbekistan was done in 2014. And then from that, their cancer plan that expired in 2022 was developed. And in that time period, they were able to create a funding proposal to expand cancer services that went to the Islamic Development Bank. And now they, as part of that process, requested a second impact review, again, to part of the monitoring and evaluation to check where they were on the recommendations. The second impact review also helped inform implementation of their award from Islamic Development Bank. And now they're looking at a new national cancer control plan, as well as planning new technical cooperation projects with IAEA for the next cycle. Another example, Burkina Faso, they actually had their first impact review in 2014. They had a second impact review in 2019, again, utilized information from the first, look at progress, identified gap areas that still existed in Burkina Faso. They quickly moved from impact review to cancer plan. So in 2020, we supported the review of their NCCP, and now looking to support them in their implementation of the cancer control plan. So the examples in terms of how IAEA PACT is taking the recommendations in conjunction with the member state from that recommendation phase, that report, to a national cancer control plan. Here are some examples. I will say in the last 3 years, we've seen a very big increase in the requests for development of these plans, because many governments see that initial assessment as really the first step, but then being able to actualize it, you need to move into that planning phase where you can prioritize and you can also assign resources. So I want to take a step back in time now, because this timeline really takes us back to 2011, the first UN high-level meeting on NCDs. And it was at that time when WHO was looking at a global action plan on NCDs. Cancer is one of those included in the global action plan. And cancer control plans are one of the milestones of the global action plan. And so that it was soon after the high-level meeting in 2012 that we first met to conceptualize an international partnership focused on cancer control. And so we met on the margins of the UICC World Cancer Congress in Montreal with different global partners that had some stake in helping countries to develop national cancer control plans, and used the ICCP, as it was named, to start to think about how we could provide technical assistance to countries to develop plans. And so we had international cancer leadership forums where we invited countries from specific regions. They were regionally focused to come together, share experiences, and really focus intentionally on the development of their plan. We also, as a partnership, developed master courses where we could engage leaders from around the globe who wanted to focus their efforts within a country on national cancer control planning. This timeline is from a recent publication where we reflected on the first 10 years of the International Cancer Control Partnership and where we want to go. And so when we started out, it was a very flat structure. Again, it was the partners coming together to share information. And we quickly realized we needed some communication. So we have a communication working group and also a technical assistance working group. This is the portal where we are able to share publicly available NCCPs and also non-communicable disease plans, because often a country will have a cancer focus within a larger NCD plan. There are resources and toolkits available at the ICCP website. And so I would encourage individuals to go there. There's a way for countries to reach out and ask for support. And so we started with a review of plans. I mentioned we had some support through the International Cancer Control Leadership Forum to help in the development of plans. That initiative was led by the U.S. National Cancer Institute, and ICCP, where it was a strong supporter and contributor to those leadership forums. After we saw, gaining traction, there were more countries that had plans. The Technical Assistance Working Group realized that now we were moving into a phase where we needed to provide some assistance to countries who wanted to implement their plans. And so thanks to the efforts of the U.S. National Cancer Institute and the partnership, one for the slides and the information on the ICCP ECHO program. And ECHO is out of University of New Mexico. It's the Extending Clinical Health Outcomes. And the way that ICCP is using the ECHO is to bring together cohorts of countries that have a national cancer control plan and focus on what are some of the barriers and opportunities and lessons learned in terms of implementing the NCCP. All of the ECHOs, whether it's ICCP or otherwise, have a didactic and also a case study set up. And the intention is for the participants to learn from each other. And so the ICCP is in its third cohort of countries. There are some countries who have stayed on across different years to continue to benefit not only from the international experts, but also from that peer-to-peer learning. And so total countries, 12, 10 in Africa, 2 in South Asia, have participated across the cohorts. So we turn as a technical assistance group to the participants to understand what are some of the implementation strategies that should be included in the curriculum. Data is always a topic for discussion in impact reviews, in plan development, and also in plan implementation. So it's not only collection, but also the use of data. Coordination at the national level among partners for implementation policy and advocacy, understanding how to cost a plan, and also looking at financing and allocation of resources for the plans. Workforce, so not only mobilizing, but also training workforce and retaining workforce. Again, data for monitoring and evaluation, improving service delivery, and implementing the system and policy changes that are necessary when maybe prioritizing differently or newly within a country. And then resource mobilization and allocation. And thinking back to some of the services that we provide, we know that a plan can also help in that mobilization of resources. So if you look at the service delivery priorities across the continuum, and again, the cancer continuum is still quite relevant here. We see countries that want to focus on cancer screening and early detection, those that want to raise awareness in the general population. And at the bottom of this, you see the number of countries that have indicated these as priorities. Education of the frontline health workers, the referral pathway, really understanding that pathway from screening through treatment, improving access to cancer treatment. That's often a priority, especially when you need to understand that referral pathway and the patient pathway. Improving the guidelines, a focus on palliative care, and then again, data. Here it's at the end of the continuum, but it's really data comes up across the entire continuum for consistency and quality of cancer registry. So this is from the 2021 cohort. So this data is available in the publication listed at the bottom, but it's really looking at across the cohort, what are some of the highest rated and lowest rated challenges. Funding, planning for sustainability, and improving service delivery were the highest rated challenges, but there's not too much difference from the building partnership, engaging stakeholders, and creating an implementation plan, also seen as challenges by some of the participants. And then looking at these contextual factors from the 2021 cohort, what are some of the priorities that are shaping how they're focused on their implementation: screening and detection, access to treatment, palliative care, partnerships, implementation resources. But what are some of the outputs? Guidelines that came up in one of the previous slides, implementing and looking at improving understanding of signs and symptoms of cancer, and of course, workforce training. The contextual challenges, again, these are all building and linked together. So late stage diagnosis has an impact on treatment, availability of resources, also links to palliative care, universal health coverage and unaffordable treatment, fragmentation of the health system, lack of funding, and then looking at implementation strategies as well. There is some literature on NCCPs. Many of these, if not all, would be available on the ICCP portal. I do think that there's a need for additional publication on NCCPs, including the development process, what works, examples from countries, the linkage between the implementation of an NCCP and impact on outcomes for cancer patients. The ICCP did a global review of available plans in 2018, and we're currently working on the update to that. So that publication should be coming out this year. We're currently doing the review of the plans from a checklist that we have. And so I think there's more that could be written, could be understood, and could be learned, both on the development, the implementation, and the monitoring and evaluation of plans. So with that, I thank you for your attention, and I look forward to the panel discussion.
Well, first of all, I would like to thank the organizers for the opportunity to share our experience in Argentina regarding cancer control plan development and implementation. My name is Julia Ismael. I am clinical oncologist, and I have not conflict of interest to declare related to this presentation. The ensuring equity in national cancer control plan is related to developing and implementation an NCCP is crucial for ensuring equity in cancer care. NCCP are comprehensive strategies that provide a framework for reducing the burden of cancer by addressing the cancer continuum of care. This is essential to take into account the needs and perspectives of all of the stakeholders. Let's analyze the national situation from 2 points of view. On the one hand, the challenges we face, and the other, the opportunities for an efficient healthcare system. Among the main challenges, we find the gap between incidence and mortality, the growth in the incidence of non-communicable disease, and inequities. Developed countries have a proportionally higher incidence than mortality for those countries compared to lower income countries. As you can see, this involves both genders, women and men. The other major challenge is the growth of the cancer burden. The incidence of cancer is growing in our country due to increased exposure to modifiable risk cancer factors and the aging of the population. This is evidenced by the 4th National Survey of Risk Factors carried out in 2018, which shows a significant increase in obesity and overweight. Poor fiber intake and sedentary lifestyle are also on the rise. In addition, there are inequities in health. Not all the population has access to the same type of healthcare, depending on their way live. In the graph, the blue or dark spots represent high-income countries and orange ones, low-income countries. We can see that 5-year survival is close to 60% in high-income countries, while it's close to half to 30% in low-income countries. These three diseases stand out: breast cancer, colon cancer, and cervix cancers, in which these gaps are observed even though there is a proven screening strategy that could improve these results. Let's move into the opportunities. In this timeline, we can see the changes in the last decade in Argentina, beginning with the creation of the Argentine NCI by presidential decree, then by decentralized by law. In 2017, the National Cancer Control Plan was planned, which has been operational since 2018. Several publications describe the line of continuous care in cancer, which range from primary prevention, screening, diagnosis, treatment, timely quality, to palliative care or patient rehabilitation as appropriate. The strategy to achieve the objectives was based on this line of continuous care, with the NCI being the governing body and in alliance with several actors. Starting from the baseline, the NCCP was planned until 2022. So far, only the results for the years 2018 and 2019 have been published. Besides, it has a strong monitoring plan. In turn, the NCCP is hosted on the UICC site, the NCCP, International Cancer Control Partnership, which has the endorsement of the prestigious organizations such as IARC, NCCN, ASCO, among others. Among the NCI's lines of work, in addition to the programs, the epidemiological surveillance, the human research training and research, the quality line stand out. This cuts across all NCI lines of action. In addition, health technology assessments, which is an essential tool for decision-making based on grade. Cancer control requires the participation and commitment of multiple actors. The actors involved in the National Cancer Control Plan were government agencies, scientific societies, and civil society organizations, and also an ad hoc advisory council. All of them supervise the correct implementation of the action of the NCCP. These multiple actors interact both in the design of public policy and its normal development. Argentina, as may you know, is a federal country, so the provinces are invited to join the National Cancer Control Plan. We still have a long road ahead to strengthen work by building consensus with multiple stakeholders, the regulatory framework to make explicit the mechanism by which innovation and high-cost technologies will be incorporated, the strengthened institutional transparency and quality mechanism in all processes of continuous care cancer. And finally, to conclude, in recent years, great advances have taken place in cancer control in our country, such as the creation of the NCI and the establishment of the first National Cancer Control Plan in Argentina. Also the incorporation of the health technology assessment for decision-making. Nevertheless, some challenges are still present for the near future that will require greater systematic planning efforts to make the best use of available resources. Thank you very much for your attention, and I will be happy to take any questions.
Hello, everybody. Thank you so much for being a part of this conversation. I'd like to invite all the panelists to come on camera. My name is Wee-Jin Ko, and I have the privilege of serving as the Chief Medical Officer here at NCCN. So as our panelists are coming on board, I'd like to pose two questions to our keynote speakers. First, Dr. Stevens, thank you so much for your presentation and for your leadership in international cancer control planning and of the PAC program within the IAEA. You've outlined some of the support systems available to countries, also pointed out some of the successes where countries have taken advantage of the resources available. How about the countries where cancer control planning has not yet become either a priority or a reality? How do you engage those countries in the context of all the other competing elements, especially in low and middle income countries, to recognize the importance of cancer control programs?
Thank you for the opportunity to talk about national cancer control plans. And what I think is we are continuing to do advocacy with these countries. We do that at the World Health Assembly. We participate in the WHO regional committee meetings. And we also advocate when member states visit the IAEA with their delegations during our annual meeting, which is our general conference that's in September. Oftentimes, our interlocutors in a country are not ministries of health because we typically interface with departments of energy or the regulators of the nuclear program, but we're constantly working through partnerships. And again, with the partners we have in the ministries of health to indicate that either that initial baseline assessment, the impact assessment, is just one of the opportunities to look at the entire cancer delivery system, but that then should be only the first step and should be followed by the development of a national cancer control plan with all of the principles that were outlined with engagement from across the community.
Thank you very much, Lisa. Dr. Ishmael, thank you for your wonderful discussion of the development of the Argentine National Control Plan. You talked about addressing disparities, but perhaps I can we also recognize within a country there's great heterogeneity of population. How does the Argentina Cancer Control Program help those who live both in urban as well as in more rural areas where access to care may be less?
Okay. In reality, the approach for individuals living in both rural and urban areas was similar, as they face similar barriers. That is why the plan approach is from public's perspective of the healthcare system. These are observed in observed in low-income individuals with limited access to healthcare services.
Right now, with all the other panelists, if I could ask each of the panelists, besides the keynote speakers who have already been introduced, to please introduce themselves and talk a little bit about what they do, and why is it that you find yourself on a panel that's discussing the utility and value of national cancer control plans across the economic spectrum. So if I can start with Dr. Albrecht.
Yes, hello, my name is Tito Albrecht. I'm a medical doctor, a public health specialist, specializing in health services research and cancer control. My work has focused on the development of guidelines and guides for national cancer control programs in Europe, and have also carried out some research later on. And I would join in Dr. Stevens, especially in saying that now we observe that the main problem is not anymore in the development of NCCPs as documents, as policy documents, but in their implementation. I think that a growing number of countries have implementation challenges, and I try to focus in my current work on the obstacles, on the barriers to the successful implementation of NCCPs.
Thank you, Dr. Albrecht. Moving on to Ms. Benda Kitaka.
So hello, everyone. Good afternoon, good morning, good evening. My name is Benda Kitaka. I'm from Kenya. I work in the cancer space as a patient's advocate as well as a policy advocate. And I currently sit on the Africa Research ECHO as the steering committee chair. Now, my role in NCCPs is actually the Africa Research ECHO is one of the platforms that we sit and discuss and also look at how we can be able to better implement NCCPs in the African continent, because this Africa Research ECHO is actually geared towards engaging both policymakers as well as practitioners in the cancer space for advocacy towards implementation of NCCPs or even formulation of NCCPs. But in my organization, Kilele Health, I also work with cancer patients, survivors, and caregivers, as well as other stakeholders, to build critical voices for advocacy towards cancer prevention. My organization is currently very much focused on working with survivors and caregivers to build their expertise in advocacy and their skills to utilize their lived experiences as a way towards cervical cancer elimination in the continent. I think I'll pause there for now. Thank you.
Thank you so much, Mr. Kitaka. Moving on to Professor Dr. Peter Rakowski.
So good morning or good afternoon. My name is Piotr Rutkowski. I represent Maria Skłodowska-Curie National Research Institute of Oncology, Warsaw, Poland. And also I'm chair of working group for National Oncological Strategy of Poland. By Minister of Health, we are responsible for monitoring and coordination of this implementation of this national control plan. So thank you for the excellent lectures. To be honest, it only demonstrates that we have similar obstacles, but a different level of the, of course, economic development and also the awareness of the cancer among the countries. So because if we are looking at the basic background of all national cancer programs, so they are almost the same. When it doesn't matter is it in Africa or in Argentina. The major problem is how to decrease inequalities, and this is what I like from Julia's presentation, that the rural areas and the urban areas have different access to prevention and also to treatment medicine. So this is a real problem. Also, in some part of Europe, this is not only the Argentina problem, because the distances, of course, can be larger, but sometimes even lacking of the bus or the train can be a real obstacle to go to the different types of oncologists or doctors who can detect your cancer. So this is very important. Another is, of course, implementation of the very basic rules for or strategy rules for prevention, including education approaches for primary prevention, because it is very, very important. We know even in Europe how we have a huge difference in the tobacco control between Eastern Europe and Western Europe. It's about 10% difference, and now even decreased by Ukrainian war and refugees, etc. So there are several different points, but I think that due to such meeting, we can learn and include the lessons from other countries from the development of our strategy. So thank you.
Thank you, Dr. Rutkowski. And certainly last but not least, Dr. Winnie So, could you make some introductory comments?
Hello, everybody. Good morning, good afternoon, and also good evening. My name is Winnie So. I'm the professor of the National School of Nursing, the Chinese University of Hong Kong. And one of my research interests is to promote and improve the accessibilities of the cancer screening services for the disadvantaged group. And I'm also honored to serve the International Society of Nurses in Cancer Care and also the Asian Oncology Nurses Societies as being the presidents and past presidents respectively. And both organizations also try their best in order to maximize the nurses' potentials in cancer control. A national cancer control plan provides governments with the strategic tool with cancer control priorities to reduce the burdens of cancer. And it covers how to address health needs of the populations across the cancer continuums, including preventions, screening, diagnosis, treatments, and support. And actually, implementations of an effective national cancer control plans cannot be achieved by the governments only. And nurses are the largest professional in the healthcare system, and we do have the central role in the multidisciplinary care of patients with cancer across the whole continuum. So in other words, nurses are a valuable asset to implement the National Cancer Control Plan and to respond to the health needs of the populations across the cancer continuum. It is really my great pleasure to be here in order to discuss these very important issues, how to implement and values of the NCCP. Thank you.
Thank you so much, Dr. So. You have all talked about the importance of not just having a document, but the implementation, and that's the kind of key step. So I'd like to ask Dr. Albrecht and Dr. Rutkowski, you represent different countries in Europe and where they have national cancer control plans. What have been the success stories and implementation that you can share going forward that has worked in your countries, and where do you look to further increase and improve the implementation of the cancer control plan? So Dr. Albrecht.
Yes, thank you for your question. I think that the success stories are mainly in the introduction of new screening programs and their stability, even through the rough times of the pandemic, where we managed to maintain them and to maintain their financing. At this point, I would already underline the second crucial issue that I see in view of NCCPs, it is in securing the adequate resources. And by resources, I don't mean only financial resources, but also human resources. I fully agree with the last speaker in underlining the role of nurses. We have different activities. We don't have only treatment, where, of course, we need highly trained and research strong medical professionals. Moving on from screening programs, I would say that we made still only initial, but important steps in recognizing the needs of cancer survivors. Over the last decades, there has been a great improvement in survival in cancer, which we are all happy about. Of course, this opens the door to new problems, new challenges, which go beyond pure treatment and have to integrate cancer control across the board. So with social services, rehabilitation, employment challenges, and so on, sometimes adapting professional skills to new jobs and so on. This is a very important issue. One thing where we are still lagging behind, and it's one of the topics that we have opened now, and which has recently become very important in Europe, is the so-called right to be forgotten. Some people don't like this word or this expression. It is the fact that cancer patients suffer financial discrimination for certain services, especially life insurance and mortgage, because they are considered, even when they're cured, they are still considered a potentially very high-risk client. And very often they are faced with rejections. This is sometimes, unfortunately, still coupled with difficulties in maintaining employment, because similarly, employers treat them as employees that might basically die soon, so that they would lose them, or they would go into permanent disability. I think this is a particularly important challenge, which is, of course, a societal challenge. It's not one that we can solve. But I think that ICCP and also organizations like NCCN are very important in bringing different partners to the table. And this is also why what we are striving for nationally. So this is one of the professional and political priorities for the near future. Thank you.
Thank you so much, Dr. Albrecht, for your insight. You've raised some really important points, and I should mention that NCCN has engaged with employers in the United States to address some of these unique needs of long-term survivors and how to reintegrate them into society. Dr. Rutkowski, lessons that you have of successes and things that you've learned in Poland?
Successes and obstacles, let's say. Thank you. I will not overlap with what Tit told, because of course some of the points are very similar. But Poland was one of the last countries which formalized national oncological strategy, because it was implemented in 2020, just at the beginning of 2020. So just before the pandemic, so in excellent time. But of course, it was not the first program, but so complex, it was the first one. So we included, like in many others, strategy after consultation with some European countries, but also with NCCN members from US, which helped us to develop this finally. We included 5 major fields. So improvement of medical staff situation and quality of education in oncology during the graduation. So not only for physicians, but also the nurses as well. And we, for example, started, I think, very nice awareness communication and some commercial for students and graduates for choosing oncology as one of the specialties, because we were lacking such specialties. And now we think that it works. So we have much more physicians willing to start oncological surgery or medical oncology or radiation oncology. So this was the first field. The second, of course, is education and primary prevention and lifestyle. And we finally started the fully reimbursed HPV vaccination in Poland this year, because before it was not fully reimbursed, and now it's a full access for 2 years of boys and girls, 12 and 13 years old girls and boys, so they can be vaccinated, and it's ongoing together with the awareness campaign, public awareness campaign. So I think that this is quite successful. Another point is, of course, patient secondary prevention. We introduced the first program for low-dose CT for lung cancer detection. We also bought all new equipments for our digital mammographs now in Poland, so we can also easily follow up the quality control for different centers. And the last two are also very interesting and important. So investing in science or research innovation. And it is very important because it's quite successful, because we increase during last 3 years about 5 to 6 times the numbers of non-commercial, so I mean investigated, initiated trials in Poland, independent trials which are funded by Polish Agency for Medical Research. So we truly increase the numbers of oncological clinical trials in Poland. And so access to both commercial and non-commercial, and we also cover the translational part for this trial. So I think that it is very important point. And the last one is in changing in the cancer care system. This year, we've also formalized, according to law, National Oncological Network with the centers of competence and also reference levels for different types of oncological care. And also, last but not least, probably we'll talk about it later, we also started to implement, because we prepared for last 2-3 years, the national guidelines for therapeutic and diagnostic guidelines for different types of the tumor. And some of them are done by adaptation of NCCN guidelines for Poland. So I think that it is according to our plans, although it was not easy because of the pandemic times when we initiated this. We are at the level of 70% of all activities planned in the National Oncological Strategy, and it's within the timelines. About 30% are a little bit delayed. So this is a current situation. And when we look at the Europe's level, of course, many of these tasks are in the line of Europe's cancer beating plan, because in Europe, last year it was also prepared the transborder, let's say, Europe's cancer beating plan, because until now, although we have European Union, but the healthcare system was left for state members. And now we have the first Europe's beating cancer plan. There are some differences or maybe different points, like, for example, it's much more attention in Europe's cancer beating plan for digitalization and data, which are very, very important. And I think that this is the future, to have more medical data on different levels available from the whole Europe. As well, I think that some more points related to the precision medicine, because there are differences between the countries, for example, with the access to molecular biology tests, not only to the drugs, but generally to the diagnostic, and also if the patient could have a drug, but they haven't the proper diagnosis, because small countries like Baltic state countries not always have access, for example, for all fancy molecular tests. So this is one of the points which was also raised by Europe's cancer beating plan. Thank you.
Thank you, Dr. Rukowski, and thank you for your leadership within the Polish cancer system. Dr. So, thank you for your leadership of the International Society of Nursing and Cancer Care and for being a steering member of the ICCP. You have raised the truly important issue of the role of nurses in cancer control. How do you, and I totally agree with that, but how do you see that nurses can play an even more important role and get a larger voice in both the development and the implementation of national cancer control plans?
Okay. So thank you for your questions. Now, and I think all of us, totally agree that a national cancer control plan provides a roadmap for a country's cancer control activities to reduce the cancer incidence and also the mortality in the countries. So because it's so important, so nurses must understand the National Cancer Control Plan and also participate in its development. And nurses also need to utilize the National Cancer Control Plan when they're caring for the patients with cancer. And in fact, nurses can, take up with various roles in this, in the National Cancer Control Plan. And I would like to make use of the impact program developed by my team and I as an example to show what are the roles of nurses in the implementations of cancer control plan. Now, the full name of the impact program is Integrative Multi-Components Programs for Promoting South Asians Cancer Screening Uptake. And actually, this program aims to educate ethnic minorities on how to prevent cancer effectively with a focus on increasing their awareness of the importance of the cancer screening uptake. And in my local community, one of the strategic directions of the cancer control emphasizes the importance of cancer prevention and early detection of cancers through screening. Now, although the cancer screening services are available for all citizens, but not all of them are equitable to access such services. And the government is also aware that additional support is needed for the ethnic minorities group, but the evidence is insufficient to identify their health needs. So therefore, my team and I first conducted a research studies to have better understanding about the situations of cancer screening uptake among the ethnic minorities and to identify their barriers to access cancer screening services. And the result of these studies inform the governments how to improve the equity of accessing cancer screening services. Now, based on the result, we develop evidence-based interventions and effectively deliver the interventions for improving accessibility of cancer screening services and also improving the uptake rate of the cancer screening. And we developed the training program for the community health workers from the minority groups in order to assist their peers in accessing the cancer screening services. We also developed a community health worker-led intervention program in order to motivate and assist the minorities to access the cancer screening services. As we have been serving the minority communities for 10 years, so we have developed strong networks with the NGOs as well as the community partners. And we are familiar with the available community resources that are able to support us in implementing the impact program. All these are very important factors for us when we develop or deliver the interventions in the community effectively and also successfully. Now, in view of the issues of the cancer health disparities maybe happen in other countries within the regions, so we shared our experience with neighboring countries in the Western Pacific regions, how to improve the uptake of the cancer screening among the disadvantaged groups. And this impact programs was recognized by the WHO as one of the social innovation strategies to address the public health problems. And the impact program and our experience have been published in the Lancet's Regional Health Western Pacific region. And I think this is an example to show the various roles of the nurses in the National Cancer Control Plan, including First, to provide the evidence to inform the government the health needs of the target group and the service gap that hinder the implementations of the cancer control plan. Second, to develop and deliver the intervention effectively. Third, to detect early signs and symptoms and prompt early interventions and treatment. Fourth, to improve accessibility of the cancer screening and the health services. And last but not the least, to promote health equity of cancer care at the national and regional levels. Thank you.
No, thank you, Dr. So wonderful examples of the role of nurses as part of the multidisciplinary team to reduce disparities and improve equity. Ms. Kithaka, you have an abundance of experience working with NCCPs, implementation strategies, working groups. Can you share some of your insights on what values NCCPs bring to large populations, both in Kenya and in the region?
Thank you. Thank you so much for the question. First, I must say I feel very privileged to be sitting on this panel today and listening to all the conversations that are ongoing, because I come from Kenya in Africa, where as of 2019, only 11 countries across the continent had actually current NCCPs. And because we recognize cancer control is an evolving practice, it's not static. When I say current, it could be that some of them were actually formulated in 2015, 2016, and have not yet been reviewed. Others may have been formulated, but have not yet started being implemented. So it's available on paper, but not necessarily in practice. Now, the question begs, what then happens in terms of surveillance to be able to tell whether it's actually working for the community or not? What about evidence-based, being able to generate information back into the system to say what policies are working and what is not working? Listening to Dr. Lisa Stevens earlier, she mentioned about the challenges that face all NCCPs, low funding, high burden of cancer, anticipated that it's actually going to double as we go along in the next 10, 20 years. And this is a big challenge in population-based approaches to cancer prevention. And so when I think about NCCPs and having been on various technical working groups that are informing the formulation of NCCPs in Africa, we see the cancer control plans as roadmaps that will provide comprehensive strategies for governments, that will provide opportunities for cancer control across the continuum, strengthening their approaches. We see that if well-resourced, cancer control plans are actually a public health approach that gives optimal access to care across the continuum, but also to prevention, but also ensures quality through standardization. And so looking at what value do NCCPs bring, needless to say, there is the increased risk awareness. If we implement cancer control plans as they should be, we are having approaches towards increasing awareness on risk factors, be they lifestyle, be they occupational, be they environmental, and therefore the public becomes more aware of things that they can do to prevent, things that they can do to manage, as well as things that they can do to be able to be involved in cancer control. Secondly, we see NCCPs as bringing the value for early detection, as well as early, timely treatment. The biggest risk and the biggest challenge that we have in Africa is late presentation. Therefore, we have not very good outcomes in cancer control. And also, we have stigma that emanates from that. Working in my country with patients and survivors, until 2019, when we started Kilele Health, we used to work in the community, tell women, go get screened. But you can see the hesitancy because all they are attending is funerals for cancer patients, and they don't get to see the cancer survivors themselves who are speaking and saying, I went through the system, I was treated, and therefore you too can be able to get through with this. So working with NCCPs, I see that there is value in increasing the higher suspicion index for both the community as well as the healthcare workers, so that we can downstage disease and be able to bring more people into cancer care, cancer control much earlier for better outcomes. Thirdly, NCCPs would help us reduce inequities in cancer control. I was listening to Dr. Rutkowski, I don't know whether I'm pronouncing that name correctly, and I was listening to how much you've done in terms of reducing inequity, in terms of increasing equity in cancer control in your region. The same with Dr. So, where you're speaking about the nurses and nursing involvement in cancer control through NCCPs. What we speak about in Africa is the barriers to access, barriers to information, barriers to treatment, to diagnostics, to even survivorship care, palliative care, and even to information, barriers to access to information. And so when we think about NCCPs, they give us an opportunity to standardize, learning from best practice from what has already been implemented, like in the regions that you're speaking about on the call today. We can be better able to fast track development of our own NCCPs using that best practice, but customizing it to our own region. Lastly, I think NCCPs bring the value of decision-making with evidence-based, especially in instances where NCCPs are well-resourced, and therefore we are better able to get evidence-based that can be used to improve practice in oncology. Regrettably, in our region again, and especially speaking into what Dr. Lisa was speaking about earlier, we don't see that when we have cancer control plans, they're well implemented, they're well resourced, they are measured for improvement, but with a proper resourcing. And what I keep saying is the challenge of resourcing of NCCPs would be the barrier to improving even that data-driven implementation or evidence-based for further improvements. And so in summation to all this, the values that I see need to be coupled with collaborative efforts so that we are better able to harness the power that already exists in NCCPs that have been proven to be working. And we can be better able to take the learnings from that and run with it in our region. Secondly, what I see is standardization, the value of bringing together technical experts, knowledge, resources, and even technologies that can better improve our government's approach to cancer control. Because as we are trying to build cancer control plans right now, technologies are improving, global standards are improving, and therefore we are playing a catch-up race of trying to catch up with what is already existing, as well as catch up with what is already evolving. Partnerships and collaborations can help us bridge some of these barriers. Thank you.
Thank you so much, Ms. Kataka. And a question back to you, Ms. Kataka and Dr. So. Well, what do you see the role, and this has been alluded to by Dr. Elbrecht, the role of patients, patient navigation, and even patient caregivers in the development and implementation of National Cancer Control Plan?
You know, may I go first, Dr. So? And I just want to build on what I was speaking into earlier. When earlier one of the speakers mentioned about the healthcare worker expertise and knowledge, and that is one of the things that need to be developed in NCCPs, I smiled because the survivors we work with and the caregivers we work with are actually qualified by their experiences. They have gone through the system, they know what is working. They have gone through the system, they know what is not working. They have gone through the system and they have come out from the other end to say, this is my lived experience. And trust me, even in literature, they say experience is the best teacher. They have the insights, they have the experience, and more importantly, they have the motivation to change the life trajectory for others. So when I think about survivors, caregivers, and what value they're bringing to NCCPs, I see it as, first of all, starting with advocacy. Dr. Lisa mentioned about the advocacy in World Health Assembly, in WHO forums, in other global forums where we're discussing like this one. The question I keep posing is, when are we going to start seeing critical masses of survivors and caregivers involved in these panels so that we're getting that lived experience as the first port of call to inform decision-making? Joining technical working groups, steering committees and panels. Secondly, evidence-based. And because they have been through the system, if we were to do polling of, for example, survivors in Africa, they would be better able to tell us about the barriers that they faced and the challenges that they faced. And we are able to map this against what is happening in other developed countries and potentially be able to look at systems improvement that are culturally appropriate. In terms of organizing, mobilizing, and informing cancer control, survivors, caregivers, and other stakeholders in the community bear a wealth of resources because they are the ones in the community. So when we have town halls or meetings that we are convening about cancer control or even implementation at the last mile, they have the capacity, the reach, and the ability, as well as the motivation. And so in my thinking, involving survivors, caregivers, perspectives, and experiences brings to the forefront the solution to the communications issue on cancer control, because they are right at the community. Of course, they have also the ability to utilize various media, be it their own stories, like in Kilele Health, we do storytelling for impact, where we are training them how to utilize their lived experience as a tool towards encouraging others to prevention. They're the ones on social media talking about what worked and what didn't work. They're the ones on social media sharing their stories to be better able to bring about how it is necessary for early detection, it is necessary for self-awareness, it is necessary that people take action early for better cancer control, reducing of cost and increasing of outcomes for better quality of life. But I want to stop there so that Dr. So can also contribute. Thank you.
Okay, thank you, Brenda. I totally agree with you that the cancer survivor really, take up a very important role in order to be up to the bridge, between the nursing, the patient's needs as well as the available of the healthcare services. Now, when I look at the terms of the patient navigations, and actually there's a definitions made by the National Cancer Institute, and which states that patient navigators as actually is the one who guide patients through the healthcare system and help them overcome barriers in order to get the care they need to be as healthy as possible. Now, and actually, various healthcare providers can take up these positions in a clinical setting, as well as some of the people being trained can being, the patient navigators in the community, just like, the community health workers. And in fact, the role of the patients navigators in the NCCP can provide a more streamlined experience for the patients with cancer by improving the care coordinations, identifying what patients require to manage their healthcare, as well as helping them to access the most appropriate services. And in fact, actually, one of the common role of the nurses is being the patient navigators as well. And I think nowadays, one of the root cause for the cancer health disparity is the challenges for accessing, cancer care services. And I think being the patient navigators or taking the role of the patient navigation is extremely important in order to fill up, the service gap as well as to reduce the cancer health disparity. Thank you.
Thank you so much, Dr. So. Following some of the comments about implementation, so this is for Dr. Stevens. You've worked in implementation processes. How do you measure, because with a plan to measure its implementation, its success, how do you measure it? What are the elements that you're introducing in different areas to measure it? And what is the role that technology can be used to help you in measuring these different outcomes?
Thanks, Wijan. So that's a complex question, but I think, you know, to the question that was posted by Ben in the Q&A, I do think implementation science is a way that we can measure, and this can be done also through putting together a monitoring and evaluation strategy during the time of the development of the National Cancer Control Plan. So what are those data points that you would need to collect? And this can get at technology. So Dr. Rutkowski mentioned a lot of the technology that's being implemented in Poland, you know, the digital mammography, a lot of the machines, the linear accelerators have a package that can be added to collect information about number of treatments, you know, per patient. And that can be linked then to data in the cancer registry. So a lot of it is about data. I mentioned that in the evaluation from the ECHO, that data was one of the points, and it's really something across the entire continuum. So not only understanding what your baseline cancer burden is, but how are you addressing it through the implementation of the plan, and how is that having an impact on mortality and survivorship, and you know, time from diagnosis to the start of treatment, the accuracy of diagnosis. So it all goes back to what kind of data are we collecting? How are we designing the implementation science activities within the country? How are we linking to other researchers? So I mentioned in the answer, if it's a nationally funded project, that can then be used in the second iteration of the National Cancer Control Plan, so when it's updated. And then in regional networks, you can look at the way that strategies are implemented in other settings that are similar, make those comparisons and make those adjustments. So I think the bottom line is data collection and then utilizing that data for decision making.
Thank you so much. And Dr. Stevens just reminded me that number one, we do encourage questions in the Q&A box, and some of the questions actually been answered in real time in that Q&A box. So you can look at some of the questions and answers presented. Dr. Ishmael, you had given a great presentation on how, you know, NCI Argentina developed a cancer control plan and looked at the implementation of it here. And earlier on, you were talking about addressing some of perhaps the rural and urban issues when we may have had some connection issues. So two questions for you. Now, if there were any further thoughts that you would like to add on, you know, the addressing it in a cancer control plan in a broad country where there may be different issues with access to care. And secondly, were there any unique challenges and opportunity in the development of the plan in Argentina that you think would be good examples for other countries?
Okay, thank you for nice question. For the implementation of the National Cancer Plan, we had many several barriers we have to face. So many of them, the other speakers mentioned it, because probably the cancer control is a multifactorial problem and needs a multifactorial approach. The main problems or barriers are financial, infrastructure, human resource, awareness, cultural and social barriers, regulatory and scarcity of data and information system. But the main problem for the implementation, planning, and sustainability are the regulatory and policy barriers, because the lack of clear policies, appropriate regulatory frameworks, and coordination among different stakeholders hampers effective plan implementation at the national level. This is particularly challenging in federal countries as Argentina, where coordinating different actors requires additional effort and leadership. The second problem that stands out is the financial barriers, because the lack of adequate and sustainable findings for plan implementations hinder the acquisition of necessary resources, including medical equipment, medication, trained personnel. It also undermines long-term predictability, sustainability, and scalability. The other problem we had faced was the human resource, the barrier, the scarcity of training healthcare professionals in oncology, and geographical imbalance in their distribution, in difficult effective plan implementation at the national level. And the other problem was the data and information system barriers, because the absence of the integrated information system limited the availability of reliable cancer data that impede monitoring and evaluation plan. The other problems to face the implementation was the other speakers as mentioned before. Thank you.
Thank you. I have a follow-up question for you, Dr. Ismail. You mentioned the barriers of financial support, and I think that was raised in Dr. Stevens' presentation also. There was some discussion about support from extra governmental sources, including foundations and the like. Can you share whether there was any success in the Argentinian National Control Plan to address these other sources of funding and support to create a sustainable long-term program?
Yes, but the main origin of funding is from the government, but we had some support from banks like World Bank and BID Bank International, the regional, and it's for the punctual line of work, not for the all the plan. The plan was only for the buy equipment and train personnel, but the was only limited.
Thank you. Dr. Albrecht, coming back to you, I'd like you to maybe expand on some of the issues that Dr. Ismail discussed, and unique challenges and opportunities that you encountered in Slovenia. And you also mentioned the importance of implementation, making a document real. What are the lessons that you have learned that you think could be broadened in scope to share with other countries and regions?
Yes, thank you very much for this question. And I will also reflect broadly, referring to the second question that was posed in the Q&A, which asked about the role, whether it is necessary for the governmental agency to be central to NCCP. Well, I will go back to Piotr, who referred to the Europe's Beating Cancer Plan. Europe's Beating Cancer Plan is the first overarching document in Europe. But we have to remember that the key work has to be done nationally. And this is always the challenge. So it's a framework, there are targets, but what has to be done mostly nationally. And this is very important to keep in mind. And of course, you need a guarantor who will pull up the resources and bring together all the stakeholders. And this usually has to be a governmental body. It can be the Ministry of Health, or it can be a National Cancer Institute. The French, for example, established the National Cancer Institute exactly for that purpose. There are different options. We should remember, and given that we come from very different countries around here, cancer is a catastrophic cost. So it has to be covered from some sort of a public scheme, because it's very difficult to imagine that any individual would bear the costs. This is referring to inequalities addressing, which needs also institutional backing. I would go back to Dr. Ismail, and when she touched upon legal barriers that, of course, again, only government can solve. It can be regarding the IT infrastructure, access to data, sharing of files, maybe even establishment of a cancer registry. We haven't mentioned this yet today, but cancer registries are one of the central instruments in measuring the impact of any kind of activity in cancer control, whether it is screening, whether it is prevention, whether it is outcomes of treatment. You need a solid cancer registry. So legal base and supporting also balanced development is, I think, one of the future challenges also in my country, because you challenged me to refer to my own country. So still, the public perception needs to change. The problem is not only the diagnosis, early diagnosis, awareness, and treatment, but also how to live later, how to accept certain increased risks because of your treatment, how to reintegrate and rehabilitate patients who have been cured. I think these challenges are now also very important. And here I would stress the education of the entire society. So this would range from awareness, which was already touched upon several times by Benda. Role of nurses. Winnie, of course, put this forward very strongly. We involved nurses in management of chronic patients in Slovenia at the level of primary care. So they are now the central figure. I wouldn't call them case managers, but they are really central to the management of chronic patients. And of course, then we come all the way through legislators, education, and employers. I recall an interesting anecdote that actually took place in Brussels, where an employer of a small enterprise explained his own experience because he had cancer when he was young, and it was of crucial challenges in his life. And then 20 years down the road, when his employee, who was young, developed cancer, he knew that he treated him completely differently than if he never had any experience and close contact with cancer. Cancer needs to be perceived as a serious disease on the one hand, which requires, of course, very energetic approaches, but on the other hand, it is a fascinating disease in the fact that you can get cured of. We forget that, of course, a successfully cured patient will come back basically healthy. Of course, they may be handicapped or impaired because of some bodily function. But compared to a diabetic or cardiovascular patient, which will have treatment for life for many decades to come, this is a completely different story. So an investment into comprehensive cancer control really addresses three issues, I would say: equality and equity. Secondly, a quality of life and overall wellness, because of course you will lose less people in their prime and also early seniority, and you will have less people suffering severe consequences of the disease if you manage it properly with preventative and early detection measures. So I think that understanding the continuum of cancer and understanding the whole trajectory and investing in all aspects of the trajectory are crucial for the future successful cancer control. Thank you.
Thank you very much, Dr. Albright. Dr. Rutkowski, you're a leader in cancer care in Poland. You've also been an active leader in working with the Ministry of Health and working with NCCN in adapting guidelines for use in Poland. Could you speak to two things here? Number one, what's the role of guidelines in national cancer control planning? And in this collaborative effort of multiple stakeholders, how has that helped further national cancer control planning and efforts within Poland?
Thank you. Of course, the standards, the guidelines are the baseline for two things. First, for the pathways of patient and decreasing inequalities. And second point, of course, it's for all quality indications which should be in line with the guidelines. So generally, we started to prepare very broadly the new guidelines, diagnostic and therapeutics, but also organizational and also some supportive issues like, for example, molecular diagnostics. And we did it in two ways. First, we did it by some guidelines by ourselves, so the novel, let's say, with our own experts, but for major cancers and more complicated ones, we decided to start the collaboration almost 2 years ago with NCCN, which was, I hope, very successful, and now finally can be formalized because according to the changes in law, we as national coordinating centers are responsible for the guidelines and for all agreements and also for adaptation of the guidelines. So we started this collaboration to adapt some the best examples of NCCN, because we know that NCCN guidelines are first, of course, high quality and high standards, but also are updated often and are in line with the recommendation of Polish HTA. So we started from cervical cancer, whereafter it was central nervous system cancer. The Polish adaptation version, head and neck cancer, ovarian cancer, and also colon cancer, and recently breast cancer. And we also prepared some key recommendations based on these guidelines in Polish and sent to the Ministry of Health, and everything will be published on the National Oncological Portal in Poland. We decided that in Polish will be also translated all algorithms which are the most important for patient pathways. So it's a vital part of all oncological strategies to have the guidelines. And as I mentioned, first are diagnostic therapeutic guidelines. Second are guidelines on the some analytical tools or this, as I mentioned, molecular biology in oncology. And the third one are organizational guidelines, which we are building now in our national oncological network. So there are three different levels, let's say, of guidelines, and of course, NCCN is. I would like to thank you for this collaboration, which was extremely good, and of course, we'll be expanding for the next years our collaboration. So it looks in this way. Of course, now the stakeholders understood that it's probably sometimes the maybe not easiest way, but the way for decreasing the demand of resources, which we sometimes haven't. And of course, adaptation process is also not so easy, because we are looking on all differences in the healthcare, in some European evidences, some procedures, but also the access to the drugs, and we are putting which drugs, which agents are reimbursed in Poland, which not, but could be available based on the guidelines. So this is how it looks. Thank you.
Yeah, and thank you, Dr. Rukowski. And I should also emphasize that it's a two-way process. It's not just adaptation of the NCCN guidelines, but NCCN learns a lot from the expertise of the Polish experts, and that has actually led to improvements in the NCCN guidelines. So thank you. This is a question I'd like to direct to three individuals: Dr. Stevens, Dr. Ishmael, and Ms. Kitaka. How can countries leverage the components of NCCP, with global cancer targets like the WHO cervical elimination initiative, the breast initiative, the childhood cancer initiatives? So you all will have each from a somewhat different perspective look at how NCCPs can help incorporate these WHO goals. Let me start with Dr. Stevens.
Thank you, Weijin. So I just want to first of all acknowledge there are several ICCP partners on the call today. And in that timeline from our paper on the 10-year history of the partnership, we did note not only the high-level meeting in 2011, but some of the other WHO initiatives that came on board. Our current review of plans, we've thought about, will those plans incorporate any of the WHO global initiatives, but I think it's probably a little bit too early. So what I think is that groups of stakeholders, whether they're Ministry of Health with advocates and academicians, can really take those global initiatives and leverage the goals to be either included in a current version of a plan, or to use them as monitoring targets for monitoring the implementation of plans that may have been in existence before the WHO initiatives came on board. And I also just want to point out that there is an IAEA global initiative on Rays of Hope, so either initiating or expanding access to radiation medicine. But so that's another global target that can be used as a benchmark for plans that exist, or you can integrate any of these targets into plans as they're being developed right now.
Thank you. Dr. Ishmael?
Indeed, the NCCP are aligned to the universal health coverage. This is the main umbrella, and the NCCPs were planned considering these ambitious objectives like elimination cervical cancer to 2030, and related to the registries, ambitious also, and all the lines of cancer control with prevention, diagnosis, and treatment opportunous and quality. And this is all related, but is the north, is not the present now for many of our countries.
Thank you. And Ms. Kitaka?
Coming last to the other two speakers, there are two things I would want to add to what they've mentioned. The first one is countries can utilize the global calls to action as tools for advocacy in country. For example, when we see Kenya signing to say that we are part of the WHO implementation of the WHO strategy for cervical cancer elimination, that's a call at national level to start thinking where the resource is going to come from for us to be able to implement this strategy. How are we going to adopt the timelines? Because 2030 is just around the corner. And so we use that as a timeline to be able to measure where are we at now, what needs to be done in order for us to get to 2030 with that goal in mind. Thirdly, it's in terms of the targets. When we look at the 90-70-90, for example, in cervical cancer, it's not the same for Kenya as it is for Malawi, as it is for Cote d'Ivoire, or as it is for the US, because different countries are at different levels. And therefore, even as the targets have been set globally, we ought to be looking at how can we personalize those in the country so that we're not rushing too fast and leaving some of the necessary components in implementation, but we can have a phased implementation of those targets, bearing in mind where the country is. The second point for me is in infrastructure strengthening. Because the WHO targets or any other global call to action on cancer control give us a roadmap to which we need to do. And there is already a well laid out plan that speaks into what needs to be done by what period, in what capacity. If countries can take these global targets as a challenge, for them to say, we may not be where we need to be, but if we work in this way and resource in this manner, our cancer control plan will be much stronger to be able to implement the global calls to action. That will provide a roadmap towards health system strengthening and will be less opportunistic, for example, in our screening programs, because we know we have a target to reach to, or in terms of vaccination for HPV, we have a target to reach to, which is an aspiration, but which gives us a target that is not movable, that we can work towards. Of course, Dr. Lisa has spoken about integration. And of course, in integration, it's an opportunity to also promote and partner. Because if we all work together and look at what country X is doing, and we say, if they're doing so much, what else can we do? We can be able to say, how can we take the learnings from that country that's doing so well for us to be able to fast track our action towards the implementation of the strategy? And for that, we require innovation. And the biggest innovation I keep asking for in such panels is that we don't leave patients and survivors from the goals, because they are the critical voice. And if we empower them, we give them the tools, we give them the mentorship, we give advocates the technical support to be able to implement the strategies. These strategies will benefit all other cancers across the continuum. It won't be just for cervical cancer, it will be benefiting the rest of the cancers as well. So I see value in governments, in countries, in partners implementing the WHO targets so that we are able to all move towards the same goal. Like, for example, we are committed to cervical cancer elimination. Thank you.
Thank you so much. The next question is to Dr. Rutkowski and Dr. Stevens. Can you talk a little bit about how to build or ensure resiliency in national cancer control plans to ensure that they remain effective and relevant to challenges such as national disasters, conflict, or political instability? So I'm going to start with Dr. Rutkowski. You've already mentioned the Polish system has had to deal with a large influx of cancer patients, and how has that required modifications or adaptations of your program?
Yes, thank you. Of course, nobody is well prepared for such disasters which could happen, like pandemic or war. Generally, of course, the most important is this existing the plan and organization. But still, what we notice first during pandemia that what we have immediately decreased, it was related to the screening programs, because of course it was easiest to limit to the patients, because we have to focus on the treatment of patients. And what we also noticed when we detect the cancer, it was no specific delays, because organization of the cancer system in Poland was a little bit outside of the centers for infectious disease, and we implemented very strict measures to protect the patients and protect the staff. But of course, during the pandemic, what we noticed that we had at about 10 to 15%, it depends on the type of the cancer, decrease of the new detected patients. And of course, after pandemia, we have huge increase of this patient. Moreover, of course, the war situation in Ukraine and the huge increase of the cancer patients, of the refugees of war, immediately after this war conflict, Poland decided that for all refugees will give the full health insurance for 1.5 years. So who crossed the border was entitled to have the same privileges as Polish citizens. What we also noticed that we have about 10% of patients from Ukraine now, especially for treatment with more advanced stages with drugs, because it is shortage of such situation. We have, of course, the problem even for these Ukrainian people who stay longer in Poland with screening programs, because they are not so willing, and maybe we cannot so well penetrate to some of them with the information. However, on the treatment, it's not so complicated, because we organize all system for translation. We have the documents in Ukrainian, etc. So, of course, if the organization exists, the guidelines exist, so we can be flexible and adapt some issues. We cannot cover everything, and we have to decide what is more important. For example, the rehabilitation or physiotherapy after the cancer treatment was also decreased during pandemic times. But if we have to decide where to put the resources, this is very, very important. And it was a very fast discussion between the Ministry of Health and oncological network what to do. The same was when the war started, and we organized the info line for in Ukrainian for patients, and we could send the patients for different oncological comprehensive cancer centers to decrease the demands for travel across the Poland. So this is what I can advise, but of course it's very important that if you have the system, you have to closely cooperate with the stakeholders and react for the crisis situation. Thank you.
From your viewpoint, on a more global perspective, and the tools that IAEA and NCCP provides, what sort of options do you have for helping countries develop resiliency in their NCCPs?
Thank you, Weijin. I want to pick up on something that Dr. Rutkowski was talking about at the end of his answer, and that is the system. So really, it's thinking about cancer control as part of the health system. And the pandemic revealed weaker health systems and even some strong health systems, and how this had an impact, as Dr. Rakowski was mentioning, not only on screening, but on access to treatment and then rehabilitation afterwards. So it's that linking to primary health care, ensuring that the cancer continuum is not seen as outside, but actually well integrated into the health system. And it goes back to data for me. So if you think about the recall programs for cancer screening, how can you ensure that those are utilized for either post-conflict, post-pandemic, post-natural disaster, to ensure that you're not losing patients who have already entered the system or should need to be invited into organized screening programs as well. And I think there are lots of other additional ways to answer, but I also know we're running short on time. But again, it's that integration.
Thank you. Again, one to Dr. So and to Dr. Ishmael. I'm going to give you only 30 seconds to answer this question here, sorry. But one of the challenges of global cancer care is HR, human resources. I think you both alluded to that. This is a challenge for each country, but it may be particularly a bigger issue for lower and middle income countries losing health human resources to higher income countries. What do each of you have in terms of maybe one thought on how this can be addressed? Dr. So?
Okay, so and I think resources is never have sufficient, not only for the low and middle income countries, but also the high income countries as well. So I think instead of just rely on the resources offered by the governments, so perhaps we can also look for and also utilize the availability of the resources in the community. I think we can just adopt some kind of the concept like social capital. And in fact, I mean, the resources is not only linked up with money, but all the resources that are able to implement and achieve the same goal as set by the NCCP. And I think actually, I have very deep experience when I implement the impact program. And actually, the healthcare providers is only one members in order to implement the NCCP, but also the patients, the clients, their family members, and the social healthcare providers, and also the availability of community resources are really, the main factors in order to make our impact program successful. I think the community resources may be negated, and we can make good use of the availability of the resources and community resources in order to maximize the impact of the NCCP.
And Dr. Ishmael, do you have a quick comment?
Yes, the scarcity of human resource was a problem previous to the COVID pandemic, but this was after that, and probably the solution or probably the solution could be turn the attention or line of care to the first line, to the primary care of cancer, to the agents, sanitary agents or nurse that could be trained to the prevention and palliative care, and in general, all the line of cancer care.
Thank you. Now, I know we're coming to the end of time, but I would like to give everybody 20 seconds, because you 2 sentences or less, for you to sort of make your last conclusion, state what you think is most critically important for you in your country or globally in National Control Cancer Plan and beyond. So I'm going to start with Dr. Albrecht.
I would say it's the to increase the role of patients. Previously, it has been mentioned that it's for the patients we are doing this, and for the populations. We are not primarily, of course, we are thinking of the professionals as well, but we are doing it for the populations of our countries. So it is important that patients are involved also in the implementation and evaluation of the plans. So how did they live through the experience of the changes that were brought about the plan? I think that this is a national and global challenge. Nationally, I think it's the strive to reduce the inequalities based on gender. We know that men, most of us are unfortunately not so keen on participating in preventative activities as women. Inequalities in social, based in social position of individuals, socioeconomic inequalities, and inequalities in health literacy that were also previously addressed. All this will bring us closer, and we need to work closely with other communities that work on prevention of NCDs. I think these would be my key messages. Thank you.
Thank you. Dr. Ishmael.
And my message is hopeful. The cancer control is possible through planning an organization for which the NCCP is a proven alternative, and is an alternative that requires effort, but it's possible included in low-income countries as Argentina, for example.
Great. Ms. Kitaka.
So I think critical factor that needs to be looked into is expanding of health literacy, especially in low and middle income countries. We have documents that sit on shelves very long before they're implemented. And even when they are, the infrastructure is built, but we don't see people utilizing because they don't know they exist, or they don't know the value of utilizing the services that are available. And so if we can increase resourcing, both in money, technical expertise, as well as opportunities for inclusion of survivors, caregivers, and people with lived experience, so that they can also be agents of change in the community, that's critical. But also including them in research and health impact monitoring and assessments, so that we have the benefits of NCCPs well documented from a patient's perspective, the risks, but also the unintended outcomes. For example, in our region where we're seeing a lot of maternal orphans by virtue of losing their parents to cancer, who is looking at the longer term impact of this in terms of the education of these children, integration into the community, their care, and these are unintended outcomes of cancer in the community. If we can think of that and expand NCCPs beyond just cancer into thinking socioeconomics of cancer and psychosocial effects of cancer, I think we'll be going places. Thank you.
Thank you. Dr. Rukowski.
First of all, thank you to be part of the panel. The main message for me is that cancer has no borders. So it would be my dream. I would love to fulfill the Europe's cancer beating plan, at least in Europe, because it really help all healthcare systems in our part of the world. But of course, it is important also for the rest of the world. And the last that we should all understand, so our citizens and also all stakeholders, that National Cancer Plan is not a fiction. We should really be devoted to that, because we can really decrease the number of cancers. We can cure more patients and live better if we are doing this. So this is my message. Thank you.
Thank you. Dr. So.
Okay, thank you. Okay. Now, cancer is a global health problem, and deliver effective and efficient cancer control plan cannot be achieved without the collective efforts of multiple stakeholders across nations. And implementations of the NCCP is everyone's responsibility. So let us work together in order to reduce the global burdens of cancer. Thank you.
Thank you. Dr. Stevens.
Thank you so much. I think there are many good points here, and while a country is developing its own national plan that's evidence-based and meets the needs of the population, I think really access for patients to treatment that may be outside the borders. So I think Dr. Rutowski mentioned, you know, cancer knows no borders. So making sure that while services are being expanded or initiated in a country, that there's actually access to those patients, especially those that are screened or identified as having cancer beyond the national borders. So that would be my top priority.
Yeah, thank you so much to all of you, Dr. Albrecht, Dr. Ishmael, Ms. Kitaka, Dr. Rutowski, Dr. So, Dr. Stevens. With your wonderful insight, we could have gone for another 2 hours, right? But thank you for sharing all your expertise, your insights. And I want to also thank the people who put this program together. Matt Izzo is the NCCN Global Policy Fellow, and together with Katie Wickwood-Preshner, devised this program and really did a wonderful job. I'm going to turn this over now to Katie for final comments. Thank you all.
Thank you so much. A sincere thank you to everyone who joined today's webinar. I would like to especially thank Dr. Ko, our moderator, as well as all our exceptional speakers for sharing their insight and expertise on these important topics, truly from the ground, making a difference for patients in Europe, in Africa, in Latin America, and globally. So thank you and kudos to all the wonderful work that you all are doing. As Weijin mentioned, this webinar would not be possible without Matt Izzo, who did most of the heavy lifting behind the scenes. So thank you to Matt and to the meetings team, Mike Abrams, Mark Geisler, and Liz Reeder for all their hard work as well. I'd also like to thank the supporters of the webinar series. Again, without your support, today would not have been possible. The recordings of these sessions will be posted on our website using this link. That will be available in a couple weeks. And we hope that you all would join us for our next session on September 19th, focused on non-medical influences and barriers to accessing high quality cancer care globally. Thank you, stay safe, and have a good day.